strengths to our pelvic floor should be pelvic health in service. We're not just gonna talk about specific, like, yeah, it's meant to be, this is meant to like be really helpful for you guys in your orthopedic practice. I think Katja and I would both agree that I'm like learning and being trained from a pelvic floor standpoint has changed how we practice orthopedics, and there's just some strategies that we found really helpful from an orthopedic MSK standpoint that we want to share with you guys. And we also want to have kind of a conversation and a discussion around a lot of these things. So that's the plan.
Okay, so the plan through the whole hour, we're just going to review and discuss the definition of core and like what it means to you guys, what it means to us. Consider the impact of core strengthening on pelvic floor issues and dysfunction. Understand how to assess rectus diastasis, if no one's heard of that, or if someone hasn't heard of that, we'll explain what it is, and what to do about it. Review screening questions and indications for referral for pelvic physio, and emphasize the importance of integrating pelvic floor issues into orthopedic practice. So like Karlyn was saying, we both have changed kind of the way we see orthopedic problems, and how the pelvic floor has a huge impact on that practice. So yeah, we want it to be as much of a discussion as possible, so if you guys have any questions or want to say anything, go for it.
Here is your chance. Okay, so who talks to their clients about core strength?
Never.
No, not Ryan, but anybody else. For sure. Okay, so what are you saying to them? How are you defining it? What does that, like, do you have clients that say, oh, I have, my back hurts, like I think my core is weak, I need to work on my core strength, and you're like, yeah, great idea. Like, what does that mean?
I think that I don't say as much as I used to.
Okay.
I think the people we see are more stiff than weak.
Okay.
But usually people come in and they're like, oh, my core is weak and that's why my back hurts. And so they just crunch or they just do oblique twists for like a week.
Okay, so then core is synonymous with
core,
abdominal strength?
To them, yeah.
To them,
core
abdominal
is
strength.
synonymous to rectus abdominis.
Rectus abdominis strength. Okay, so that's what a lot of people are thinking. What do you think?
What do I think? I think
Yeah.
obviously the inner and the outer core is a lot more than that.
Okay, so using language of inner outer core, is that like fairly, or is everyone like nodding with that in terms of language and how they think about it? Okay.
I think, I'll talk about inner unit, outer unit stuff, talk about chains, but I think there's also a shift about like, it's not really about what you're using, but as long as you can stabilize whatever you use, it doesn't really matter what strategy you're using to stabilize.
Okay.
As opposed to specifically like, talking about specific muscles or asking them to like pull in your belly button when you do this. It's just getting them to do an exercise and saying, what I want is for there to be no movement here. Picture that there's a glass of water on your pelvis and they don't like,
Great.
as in like the strategy that they use to stabilize doesn't really matter where it's coming from. It's
Okay.
kind of,
So core is essentially a strategy for stability,
sure.
but you're saying strategy doesn't necessarily matter what they're using,
Well, yeah, like not
as long as they're able to maintain.
or that's something that I would
Okay.
say like what is core, but how I kind of integrate it.
Yeah.
I'm just gonna add, I think I like to talk about the core as a cylinder that
Yeah.
expands around all
Container.
sides and has a top and bottom, because I think a lot of people just think about the anterior, so they just think about like a
the
plane
front
here, and they
here.
don't think about the 3D.
Yeah.
So
I like that. Anyone else use that kind of container analogy? Yeah, I think that's cool. Okay. How do you assess core strength? Objectively, what are you doing?
McGill endurance.
McGill endurance, like a curl up, like.
So an anterior hold at like 40 degrees or something. And
Yeah.
Like an extension, like a prone extension off the table,
Yeah.
and side bridge.
Okay. Anyone else have any other ways they assess core strength?
I ask them what movements are bothering them and then watch them do it.
And see what are you looking, like just their control, their strategy, their ability to, yeah, okay. So you're applying it then to potentially any movement, position.
How much they can deadlift?
How much they can deadlift?
It's the only one that matters. Right, AC?
Max, their 1 rep max in a
Yeah.
deadlift.
Conventional
Is that
deadlift,
max?
just like AC told me.
Yeah.
I think you have to assess it specific to their goals and what they need their core for, because it can be anywhere on the spectrum from motor control, endurance, strain,
Yeah.
and how to help them, right?
Yeah.
So you gotta really, you can't assess all of it.
Yeah.
One could, but really the goal is specific to their
Yeah.
demands.
I like that. I feel like we're capturing the fact that it's like it's not just about one muscle. It's not even necessarily about a group of muscles. It's that ability to maintain that control in that position. Yeah, I like what I'm hearing. It's good.
Okay, so
This stuff. Oh yeah.
so kind of what we were talking about before with like inner outer core, from like a pelvic floor standpoint, we've kind of learned in terms of like anticipatory core versus reactive core. So the anticipatory core is kind of like your inner core, I guess. So it's your four main muscles, your diaphragm, pelvic floor, TA, and multifidus. And they're kind of the muscles that they come on like a split second before your reactive core, so your outer core muscles. So they respond first before any movement, kind of like create a bit of a central stable anchor around like spine, pelvis, those areas. So
That would be like that container,
Yeah,
like that inner container that you're sort of talking about.
and then reactive core is like obviously all the rest of the main muscle groups, and it's not again just like your erectors or your rectus abdominis. It's your glutes and your TFL, deep hip rotators, pretty much anything that's around that area that's a main driver of movement. And then that's where your like anatomy slings come in. Your like posterior oblique, lateral, anterior oblique, deep longitudinal slings. Has everyone heard of those before?
That should be reviewed.
Yeah. Okay. So the management of core and how you use your core impacts your intra-abdominal pressure. So the pressure that's inside of your system and how these muscles all like work together. And they're important in the next.
Yeah, so I think this is the piece that might be new for some people to think about. But when you're talking about that container, ultimately, like the other role that those muscles play is in maintaining or controlling intra-abdominal pressure. Does anybody talk about pressure or look at that stuff with clients? Because this is from a pelvic health point of view, what we where we sort of see some issues, right? So Julie Weeb kind of came up and developed this sort of conceptual, like this way of talking about or framing it, like as a piston. Has anyone heard that before? Like that piston model, right? So diaphragm descends, pelvic floor lengthens on an inhale. On an inhale where the diaphragm is actually moving, right? So someone who's actually taking a diaphragmatic breath. And then on exhale, you actually get a recoil of the pelvic floor as the diaphragm ascends, right? So that essentially allows for that intra-abdominal pressure to be kind of maintained, and that should be happening like in a healthy individual. That happens automatically. That isn't necessarily something that they would have to think about, right? Like for those, like I'm assuming that most people in this room haven't experienced any pelvic floor dysfunction, right? And so if you have, you'll realize that like if you're leaking when you run, trying to hold your pelvic floor when you run is not going to work. That's not going to be an effective strategy, right? So what's happening in that person that's experiencing incontinence when they run is this isn't working automatically anymore, right? The lengthening and the natural recoil as they breathe isn't working anymore. I feel like with pregnancy, one of the reasons why that happens is because during pregnancy, you really lose your ability to breathe diaphragmatically because there's baby in the way, right? And that can be one of the culprits for why this doesn't become automatic, right? And so their pressure system is sort of thrown off. It can also mean that if they can't breathe diaphragmatically, if they're inhaling or they're holding their breath, it's potentially causing them to increase that intra-abdominal pressure, which it has to go somewhere, right? And that's essentially like the balloon model, but the pressure has to go somewhere, and if it's directed towards the bladder, that might be why they're leaking. And it's not necessarily about the strength of their pelvic floor, but it's about the fact that they're not managing that intra-abdominal pressure appropriately, and it's going down on their bladder. Is it like, nothing, yeah, okay. So if you, there's a few balloons out there. So this is a good demo for clients who are potentially, and even for us to sort of like visualize and think about more from like an intra-abdominal pressure standpoint, right? So if the top of the balloon is your diaphragm and the bottom of the balloon is your pelvic floor, this is the container that Ryan's talking about, right? Spinal muscles at the back, abdominal muscles essentially at the front, right? if you have someone whose strategy for stability is a breath hold, right, where they are holding their breath, this balloon has too much air in it, or holding their breath, or gripping their abs. So if you had this container and you squished the top of it and squished like the back and the front of it, that is going to lead to an increase in pressure that has to go somewhere. Where is it going to go? Down at their pelvic floor, right? So this is where if you're training core strength and you see a pattern or a strategy that involves a breath hold and a gripping, I guarantee they're bulging or creating pressure down at their pelvic floor. If you have a client who's doing that and is potentially at a higher risk of a prolapse, which is like especially in women, does everybody know what a prolapse is? Please say no if you don't. That's going to create issues, right? We see pelvic organ prolapse in women that have not had kids, right? And a lot of that has to do with years and years of training and exercise. Potentially, that's creating situations of lots and lots of pressure down at pelvic floor.
We see a lot of like high intensity athletes, like CrossFitters, or people who are just like anytime they do any movement, they're just like, doing this like Valsalva maneuver essentially, like every time they lift or every time they do core, they do
anything that requires lots and lots of gripping. The other situation that we'll see from a balloon standpoint is potentially gripping pelvic floor and holding breath or gripping from like an abdominal or a diaphragm standpoint, or like not even necessarily getting good diaphragmatic breath, and the breath just pops up into the apex of their lungs, and the pressure in the balloon goes forward through their abdominal wall. So these are the situations of like rectus diastasis, potentially like hernias that you might be seeing in this population. Like hernias are like a pressure management failure, right? And that's why that's happening. So this is not exclusive to pregnant women. I have 2 male orthopedic clients on my caseload right now that get significant doming and tenting through their abdominal wall when they lift their head. So when we talk about how you assess core strength, is that something that you've looked at before? When someone lifts their head, what's happening along their abdominal wall, right? In that McGill hold, and we'll go through like a demo of like exactly kind of what to look for and what to look at, but what's happening along that abdominal wall gives an indication of how they're managing that intra-abdominal pressure, and whether or not they're doing it well.
Does everyone know what a rectus diastasis is?
Everybody's just nodding.
Is there anyone that hasn't? No.
The research. We lost it.
Just use it or maybe like use the remote go.
Aside from the intra-abdominal pressure piece, the other thing that happens with that natural pelvic floor recoil, so if someone's getting a good diaphragmatic breath, their diaphragm descends and lengthens, their pelvic floor lengthens, and then they get that natural recoiling of pelvic floor or contraction on exhale, that also creates tension in a couple of other directions. You get co-contraction of TA, which is going to tension the linea alba, and you also get tensioning through like the levator ani, like arcuate tendon, through obturator internus, which tensions deep hip rotators. So this is another thing where, like, as far as like helping clients connect with like abdominal wall or glutes, the pelvic floor works like really, really well as a cue to facilitate that because of those like fascial connections. Yeah. Is this working? Okay. Who assesses for rectus diastasis? Who's looked at this on a client before?
I've done it once.
What did you notice?
I had no idea what I was doing.
Okay. Yes.
It was a client who came into me and she said she had some back pain and she was hoping that to strengthen her abdominals because after pregnancy she was never the same. So I feel like I have like a lump for like a whole year. And I palpated, I watched her curl up to see her patterns, and I was like, there's something there. What do we do? Like, that was kind of it.
Yeah.
And I referred her to the pelvic.
Awesome. Yeah. I feel like will you be able to see if we do this, if we kind of do a demo? I mean, you guys can stand in the back row and there we go. My advice to you on this would be to start anybody that's coming coming in where you're thinking about core strength, just look, it takes 2 seconds to look at this. You will be surprised how often you pick something up. More often than not. 100% of women in their 3rd trimester have diastasis. I mean, it's weird that we label it with like a term like that because it's not common, but. Okay. My hands are okay, so if your client's gonna be, sorry, we don't have a pillow for you. And my hands are really, really big. Okay, so they're lying on their back, in crook lying, right, knees bent. Ideally, initially, you don't give them any strategy. You just say, all I want you to do is just lift your head off the pillow.
That's worse. That's worse.
Okay, so palpating along linea alba, sometimes even just in a resting position, you can get an idea of tension. The recent research is really now starting to shift towards the distance between the left and right sides of rectus abdominis isn't actually what matters. It's their ability to generate tension along the linea alba. So you can see, because there's such a varying degree of normal, and so you can see 3 finger gaps in people, but they've got good tension. That's less concerning to me when I see like even like a 1 to 2 finger gap where I'm like sinking.
When you feel it, you'll just like sink.
You just you just feel like there's no linea alba, like you'll go. Those are the more obvious ones. But yeah, generally like within normal range is about 1 finger breadth down the line. I mean like half above and half below if we're gonna get super technical. But usually it's about a finger. So as Katja lifts her head up, I'm going to be feeling along the linea alba to see what the tension is, but I'm also going to be looking. Does anybody see here? You actually get almost like a little bit of a pocket of air. So go back down. So 2 things are going to happen. Either you're going to feel, or 3 things. You're going to feel either good tension, you're going to sink and feel like you can go, or you're going to see that almost like a little bit of like a bubbling effect. And this is what I tend to see more, like not necessarily like postpartum population, but like the 2 guys I'm thinking of right now. I mean, theirs is like really obvious. Like you could see it like through their shirt when they transition from laying to stand. Like it's that obvious. They're just not managing pressure well at all, right? One, by the way, has hip away. That's it. It's the only, like he doesn't have any back or abdominal issues. Okay, so as Katja lifts again, we'd be looking above where we see a little bit of that bubbling. We'd be looking at like umbilicus and then about 1 inch or 2 below. You can assess just down that line. I mean, it's super quick and then done. I probably wouldn't have asked you even to lift that many times. Okay, does anybody have questions about that?
What do you mean by bubbling?
You maybe can't see, but she actually is getting a little bit of a doming
Like
or
it almost is
tending.
like domes.
It pops up.
You mean that's not from the rectus abdominis?
So that's an increase in intra-abdominal pressure that has to go somewhere, and she's not getting good tensioning through her linea alba right now above her umbilicus, and it's popping up. So
would you say catches is a problem, or is that a normal amount?
no,
Okay.
this is actually, which is why we used her as a demo. There's backstory we don't need to get into. But I said no. This I would say is in her strategy right now, and I mean she knows how to change it, but she's not, so that you get more out of this demo. During my pregnancy, mine was really obvious. Like you would see like really, really obvious tenting. Okay, so if we cue Katja to coordinate that piston, so inhaling, right, diaphragm descends, abdominal wall expands, that doesn't create the bubble, right? Pelvic floor lengthens, and then as she exhales, she engages her pelvic floor and lifts her head up. Can anybody see from back there? Right? So her pressure system is better managed in that situation, and she doesn't get that doming, that tension, right?
Can you guys see the difference?
So what with that client that you have, right, who's got that diastasis, if you cue this and it changes, right, that would be like, oh, okay, that's encouraging, right? And then essentially so Nicole sat in on a session that I did with a client that I have post-pregnancy who has like, I was like sinking, you essentially just start progressing abdominal exercises and seeing how they do and whether or not they can maintain this strategy. Can they create enough like support through and tension through their linea alba that tenting going doesn't happen? That's kind of a green light to progress those exercises. But as soon as you see them like bursting through that linea alba, that to me is then it's not a good idea, right? Rectus diastasis, you Google that, it's like, okay, don't do all of these exercises. That's horrible recommendations. It really depends on how that person can control pressure in that situation, right? And then that's where the screening for like, okay, do you feel pressure kind of bulging down towards your like pelvic floor? Are you feeling any heaviness or pressure there? Are you leaking? Or are you experiencing any pain with that? If those three things are no, then green light and go, right? Good. Okay. Any questions about that? So look for the tension along the linea alba. Make sure it should feel like a good like trampoline like amount of kind of stiffness.
It's
If
very
you're
obvious
it's
difference.
really obvious, and then if you cue that like exhale and engage your pelvic floor, like just help them facilitate that kind of inner core piston, it should change. And if it doesn't, they might not know how to engage their pelvic floor. Like, I don't know who is cueing like TA over pelvic floor. Like if you're cueing inner core, what cues are you using with your clients?
I'm just gonna use a global strategy.
Yeah, so what's your global strategy?
I get them to think more of like trying to think.
What do you mean global strategy? Just because it's like everything co-contracts anyway, so
Yeah,
you don't worry about
yeah.
isolating TA, like whatever.
I've never really felt like we could really isolate something when we go into a functional movement anyways. It's like saying, to me it's always like been saying, oh, when you squat you're getting your glutes over your quads or something like that because you're moving your knees past your toes or behind your toes, right? Like you're gonna get co-activation from all those muscle groups.
Yeah.
So I've always just tended to get them to essentially contract everything, trying to create that hollow core. Mostly gastrocs and aconius, but yeah.
Okay.
I think I do the similar thing. Just create some tension in the core. Try to think about co-contracting the muscles if it is.
Is breathing something that you look at?
Not like in the initial stages, yes. If I'm noticing a really obvious issue with their breathing, but I wouldn't say if someone gets pain when they're sitting at work or pain when they're doing a squat, necessarily think about breathing.
Okay.
I'd say like again generally for even just basic core stuff, I'll usually give a cue, like I'll do stuff like crook lying, hands under pelvis, having them do like alternate like hip flexions for example without moving that pelvis and seeing how they do that. You see what I'm saying? Like without having a shift and then making sure that they are breathing throughout that. If there's some people are motor morons and don't know what it means to engage your core and what it means to kind of stabilize the pelvis. In that case, I might go to like the old school, like, okay, pull your belly button towards your spine, but like I don't want you to squish my hand. I want you to keep that neutral spine. And like, okay, pretend like you have to pee, and then one of those cues will be like, oh, like that makes sense to me, or like
and
now I
then you ride with that.
feel something, making sure they're breathing while they're doing it. But I've never done like the piston. Like I don't like I understand the concept.
Yeah.
I've never done it that way.
The other way, like the other exercise, so similar to that, like diastasis assessment. This is fine. We don't have tons of words on slides, anyways. The diastasis assessment. So if you look at somebody doing like just like a traditional, like a glute bridge, right? Like super simple and like entry level kind of glute exercise. How many people when they do that say they feel their glutes? Do you have clients? Half. 50-50. What do you do with the 50% that don't feel their glutes?
I give them cues to engage their glutes.
So asking them to squeeze glutes.
Sure.
Yeah. Okay. What happens when you squeeze your glutes in a glute bridge? Or in anything for that matter. Squat.
Posterior pelvic tilt.
Posterior pelvic tilt. Yeah. So in a posterior pelvic tilt, what happens to the pelvic floor? Like this. Yeah. How do muscles do eccentrically?
If they're strong, well,
And if they're not?
worthy.
Yeah. Yeah, so that is something to keep in mind when you're like, this is again just thinking about the impact on pelvic floor, right? So if I see someone who their only strategy for using their glutes is to like posterior pelvic tilts, often that client is then at a higher risk for incontinence and leaking, especially because the anterior pelvic floor is primarily lengthened in that situation, right? So the female runners that are running with really, really upright posture and their butt tucked are more likely to leak just because of the position that their pelvis is in, right? So what I often will do for glutes in a glute bridge that works really well is instead of cueing someone to squeeze their bum, I'll say stay neutral, stay in your neutral pelvis, neutral back, and engage pelvic floor. So as you exhale, engage your pelvic floor. I mean, you could cue TA too if you feel like they're good at doing that. They're the same, they're one and the same thing. Whatever, if people are uncomfortable asking their clients to stop their pee, I mean, obviously, we've gotten really comfortable with that. But if there's a cueing that works for you from a TA standpoint and you're confident that they're not just firing up their obliques, cue them to engage their pelvic floor and get them to lift into their glute bridge and see if it changes and shifts that effort to their glutes. Because they will be creating tension through those, like that obturator and internus and those deep hip rotators. And it takes the 50% that don't feel their glutes will probably feel it. I feel like that would be, I mean, if we had enough space, everybody go down and do glute bridges. Who doesn't feel their butt in glute bridge? Anyone? Abby, come here. My glutes suck. Yes. How's your pelvic floor? You don't have to answer that.
You tell me.
Yeah. Okay, so go on your back. Okay, so when you don't think about any of the things. What do you think? Should be fine.
Okay.
So do a bridge.
Oh, they're working.
Okay. That's an example.
I'm thinking about it.
You're thinking about your pelvic floor.
Okay.
What's that?
Nope, they're gone again. It's fine.
Okay, so then what would you think of doing to help them on? Would you just be like, okay, well,
So
if I
my initial, for me, it is always to just squeeze my
squeeze
glutes.
your bum
Yes.
and lift?
Yeah.
Yeah. Okay, and so
That's-
come
yeah.
back. Do it again. Okay, come back down. Do you feel like you have a decent connection to the pelvic floor? I guess we'll
It's
start
not
there.
something I have to think about.
Okay, so if you inhale, take a breath in, and let that one go, exhale. Okay, so inhale again. As you blow out, so as you exhale, do what you would do if you were like stopping your pee, stopping yourself from passing gas. Can you feel like a lifting or tensioning up? Okay, let that go as you inhale. Exhale and re-engage your pelvic floor, and then lift your bum. Okay, stay up here for a second. Do you feel glutes right now?
Yeah.
Okay. The other, do you feel like
just on activation? They
yeah,
were,
yeah. And then what if you weren't? If you were like, I don't know, then I'd say here, take another inhale, and as you exhale, re-engage your pelvic floor. So don't squeeze your bum,
Yeah.
but think about lifting through your pelvic floor. You feel your glutes?
It feels like they're activating just as I'm squeezing.
Yeah, you're squeezing
My
pelvic
glutes
floor.
are
You're not
activating
squeezing
with
your
my
bum.
pelvic floor,
Yeah. So instead of giving them like the cue to squeeze their glutes, which is gonna pull them into posterior pelvic tilt, this is an alternate, and it works.
Yeah.
Yeah. Oh, and then come back down. Nice.
Good.
You wanna add anything to that?
Oh, I think you.
No, I was just gonna say sometimes like if
You still need me?
Thank you.
I have a client who's like a little bit more like complex and I'm just almost a bit unsure of where to even start. I get them on their back and I just tell them to take a deep breath in and I just watch how they're breathing. And I don't know, 8 times out of 10, they do this and they just breathe up here and everything is up here and they're just like not engaging your diaphragm whatsoever. And so that's just somewhere to start education piece wise is teaching people how to breathe again properly by engaging that piston. So
And this, the breathing, like, I know it's not, like, I remember, like, cardio rest physio at school, you're teaching people deep breathing, like, oh, like, you're never gonna have to do this. You'd be surprised how powerful and impactful this can be. That piston relies on the movement of the diaphragm, and if that is lost, they're not going to be getting that automatic movement of their pelvic floor. It's just not going to be happening.
Because nothing's going to be changing pressure-wise either, right? It's
Right?
not increasing
Which is going to
pressure.
change how they create tension through their linea alba. It's going to change how they create tension up through their glutes, right? All of that stuff kind of comes into play. So that definitely makes a pretty big difference. And again, if they're breathing well and that's happening automatically, you don't have to cue this stuff and you can go to something further. But there's going to be a population of people where this stuff becomes.
Yeah. And sometimes people breathe really, really well into like diaphragmatic breathing, and then you get them into like a plank and they just do this and they just hold everything and nothing moves. And so that's also a problem.
How did we fix this?
I think it's just your computer's off. It's
I'm
the
not
battery was low.
changing this now. Okay.
Okay, well, we're going to try this one.
Yeah. Oh, my battery's dead.
Well, we were going to get you to read the next slide, but I'll read it to you.
It'll take me like probably 5 minutes.
Okay, so
This is a wordy slide, so
yeah.
close your eyes and think about what the words
I'm
are.
about to say.
Wait. Yeah.
Okay, so essentially we're just trying to get them to like kind of rethink about how they define the core. So rather than just thinking of it as like one structure working, like one structure is weak, their obliques are weak, their glutes are weak, whatever it is, it's more looking at it as like a strategy for central control, strength, and stability, right? It's this is where it gets wordy, but I'm gonna read it. A system that harnesses the neuromuscular relationship that exists between the anticipatory core, reactive core, intra-abdominal pressure, stability cycle, sensory system, and the brain, right? So it's like everything involved. It's not just one thing. So it's not one single muscle, it's a group of muscles, and it's like an inside-out cascade of force that provides both stability and flexibility required to respond to the task.
The thing, I don't know what stands out to you guys when you hear that really wordy definition. I'm making sure it's you. The thing I think that I am drawn to with that definition, or the part of it that I think is interesting, is this concept of like both stability and flexibility. So, Matt, are you still in that corner?
Yep.
I'm curious to hear too, like when you are cueing like everything on like maximum tension, that's great for like from a stability standpoint, but then does that allow for enough flexibility to actually move? Right? Because it's not like, okay, everything on as much as possible. Because like, okay, now go like kick that soccer ball, right? There has to be room for like some fluidity, right? It's not like maximum stiffness is necessarily what we're going for.
Tension is an overbearing term for it. I think you were asking somebody, whether it was Jared or it might have been somebody else, about, do you leave room for breathing as well, right?
Yeah.
I don't think trying to create maximum tension around somebody's back who's having pain or discomfort necessarily means 100% where you're doing the Valsalva maneuver either.
Yeah.
I don't think we should be trying to coach that either, because they do need to be able to move, right?
Yeah.
So I think we're always trying to look for that, and I don't think, maybe that's the hard thing when you look at research, right? I don't think there's one perfect strategy for each person, right?
No.
Some of our soccer players or higher level athletes, some of the rugby players we see, we're going to be giving them far different strategies than a new mother or a 60-year-old guy with hip away as well. Right? And I think it's trying to
what they're having a hard time with.
I think it's trying to find
that
that balance with it as well.
Anybody else have any comments on that definition? Debate? I like it's. No?
More so just like no one thinking of it as like how long someone can hold plank for, or just because they have back pain means their core is weak. Like it's more of a strategy and what dysfunctions are happening within that strategy.
Yeah, and I think from even the conversation at the beginning, I think that we as a group have a pretty good you're thinking about core already as more than just how long you can hold a plank, which is good. I think my encouragement would be and where we can kind of go with this is arguing that maybe the strategy does matter in certain situations, and maybe part of what we're changing isn't strength, but it's strategy, maybe laughing at my pop-up. So pelvic floor dysfunction, which is primarily what you're gonna think of is like, okay, somebody's leaking, right? They're leaking urine when they cough, sneeze, laugh, run, or jump. They are feeling like vaginal pressure, heaviness if they're on their feet for a long time. They're having pain with sex. They're having pelvic pain when they just sit. Whatever it happens to be, like those things we can kind of lump under one umbrella and label that pelvic floor dysfunction. Pelvic floor dysfunction is ultimately a dysfunctional core. It's a core strategy that's not working for them, right? And so this kind of comes back to, again, like our encouragement to, as clinicians, to be asking some of these questions to your clients that are presenting with low back pain, hip pain, any pelvic girdle issues. And it doesn't mean as soon as they say yes to one of these questions that you have to refer them to a pelvic floor physio. It's just so that you're aware of that their core isn't working the way that it's supposed to, and that is evidence of that, right? If they're having, like, I mean, painful sex might not be the first question that you're comfortable asking your female clients, but if you are comfortable with them and you ask them that, again, that's an indication that they are over recruiting their pelvic floor. That is their strategy for central stability, and it's impacting another area of their life, right? And you might be the first person that picks up on that and looks at, okay, what is it in their core that they're not using well, and can we give them a new strategy that offloads their pelvic floor, right? And it might not be, if that's not their goal, then they don't have to come and see a pelvic floor therapist, right? If they came to you for something else, but at least it gives you that piece of information of kind of what is going on in their pelvic floor. And leaking doesn't mean that it's weak, necessarily. It could be more of a pressure problem, right?
And from my experience, like most of the time, I know like some of the times that people have come for pelvic floor physio, but if you ask them, just say like, oh, have you ever leaked when you ran? Most people are like pretty willing to give up that information. You get some that aren't, but most are just like, yeah, I am actually, and they're almost like relieved that you asked them that question. So
you're at the end of the day, like, you're a healthcare professional, right? I don't know if sometimes it's our own discomfort with the questions, but I'm just strongly encourage you just like scream, because it's a piece of that puzzle. It does not, and it shouldn't be like, oh, it's the pelvic floor, like I can't see you anymore. You have to go see Katja, or you have to go see her, right? Like, that's really not at all the issue. It's just, it gives you, like, let that encourage you to like clinically think, okay, why might that be happening, and is that relevant to the rest of their presentation, right? Are they, when they're doing, and then are you training them to, like, I mean, in their training, are they holding their breath and gripping everything? Are they creating too much sort of compression? What impact is that having from a pressure system standpoint? And might that be having a negative effect on their pelvic floor without you necessarily realizing it because you haven't asked, right?
And there's, I mean, it's coming up with the slides, but we do have like a questionnaire if you don't really want to ask, or if there's more things that you want to delve into, you can give them a questionnaire and they can fill it out saying yes or no to all the questions. If you're suspecting that something else is going on, I think it's on OneDrive. It's going to come up, but
yeah, you guys have access. I don't know if anybody's, I think some of you have used that before. I know from when I used here in the good old days, yeah. But yeah, essentially thinking about core dysfunction, like pelvic floor dysfunction is synonymous with the core's not working. Okay, so what other examples clinically do you see of like core, I guess, dysfunction, if we call it that, as opposed to weakness?
like, what do you see people doing when they're doing like the core exercise, for example?
Other than holding your breath.
Holding the breath is a good example. Yeah.
We've talked about a few.
Breath hold. Yeah, we've talked about a few. Breath holding, or like an apical breathing pattern. What others?
Keeping their pelvis neutral, like going into too much like anterior tilts or posterior? Or?
Yeah, so not keeping pelvis neutral. Yeah. So if somebody's going into anterior pelvic tilts, what is their strategy for maintaining stability? What might they be using a lot of? Flexors, potentially. What else?
Any global muscle really?
Like a little bit, yeah. Or like excessive posterior pelvic tilts, right? Their strategy,
Like butt crunches.
That
Squeezing
butt
your
clenching, like ab clenching, like that's like essentially like yeah. So if you're asking, this is where I think I challenge you to think like when okay, so they can maintain their stability. Like let's say you're looking at like okay, so another example of how to assess. Like who looks at balance? Right, so you're assessing balance. Balance is a good example, a good kind of general example of what their stability strategy might be to stand on one foot. I mean, there's a million things that come into play with that, like outside of even core, like ankle, whatever, stuff like that. But in that situation, what is their strategy to maintain that balance? And you'll see it. You'll see people. So you'll see the posterior pelvic tilts as one potentially. Breath holding, ab gripping. Who blames poor glute strength for stuff?
Some stuff, sure.
Yeah, for some stuff, not for everything. Headaches. Glutes are weak. Your glutes are weak. And again, like we're not here saying the pelvic floor is to blame for everything either, right? I feel like that's always the joke. That the pelvic floor is responsible for your sore neck or your sore jaw or whatever, but that's not it either, right? But it's this, yeah. So let's say like hamstrings compensating for glutes in a deadlift, right? So people doing deadlifts and they're not using their glutes, they're just using their erectors and their hamstrings, right? And so when you're teaching that deadlift, Matt, that global stability strategy in their deadlift, are you telling them to lift with their back as more or their hamstrings more, or are you trying to get them to lift more with their glutes?
I'm trying to get them to lift pain-free, most cases. I
What?
actually, the most recent
Pain-free.
research actually just showed, coming in with deadlifts, that it's not actually bad to lift with your back.
No.
So I think, again, we're looking at
Yeah, not
strategies that
necessarily.
work on that specific person. I think
Right.
we have to be adaptable to.
So if
different
that
body types
person
and
is
different
having
sizes.
pain in a deadlift
Yeah.
because they're in their situation they're lifting with their back, then are you gonna try to offer them a different strategy?
Yeah, and I think that's
Yeah, I agree 100%. Lifting with your back is not necessarily a bad thing until it's giving you a problem.
until it's a bad thing.
Yeah, right? It's like squatting into flexion, like below 90. Like, doesn't matter unless it matters to you, right? Like, if it's becoming an issue for you, yeah. Back gripping in a plank. See that sometimes? So not being able to maintain neutral in a plank would be, that just, again, is their example of a strategy. Yeah. Again, I think the encouragement here from a strategy standpoint is just to think about the impact, the strategy that you're coaching or you're cueing or you're training. Just pause and think about the impact on their pelvic floor. That would be, because you might think that strategy is working for them, but they might not be telling you that they're leaking when they lift, right? Or they're experiencing like urgency, frequency, where they pee every hour, or they wake up 3 times a night to go pee and they're 30 and haven't had a kid. Even if you've had a kid, that's not okay, right? So I think that, that's the piece from like a clinical standpoint where like you are having an impact on their pelvic floor, whether you know it or not, right? Just because it's not something that you're necessarily directly assessing. It's good to just good to be mindful of that.
Another thing that I find really helpful to look at, and I find this more, just from my experience with women, who have a lot of women have the initial instinct to always hold their abs in, and always, like, with anything, doesn't matter if they're working out or just standing. So sometimes I'll literally just get somebody to stand there and just see if they can like disengage their abs, and if they can't, and because then it kind of indicates that they can't use their diaphragm properly, right? Because they're just not able,
Sucking in their stomach.
they like literally don't have the ability to let go. They just can't, because they're holding and just creating so much pressure within their system, right? So it's another really simple like thing that I sometimes look at, just if they're not able to kind of.
Yeah, I mean, and if you're looking at breathing with someone, right, like it might be different in a supported position. Like if they're laying down or sitting, that might look really different, but then you stand them up in that position. And if it is a stability issue or if it is pain that's driving that, it would be like you're gripping your abs, like you're just standing there. That's not a strenuous task. right? Why the need to hold that much tension, right? And investigate that a little bit and see what makes sense. Yeah. This is the screening questionnaire.
So,
sorry.
yeah, if you're not comfortable asking those questions, you can just give this, if you're thinking something else, pelvic floor might be going on, you can give out this questionnaire, get them to fill it out, it gives you a pretty good idea, most people will be fairly honest. And then you can incorporate some of the techniques that we talked about today with them. If that still doesn't work, like you can always refer
For sure.
But it's just something it gives you strategies to then think about how you can incorporate pelvic floor training with them to see if that changes anything.
The other option of this too, and I don't know if anybody's done this, but just like say, and I think this definitely happened when I was here before I was born. But like, if you're having a client where you're just like, I don't know what they're doing with their inner core, you can't isolate pelvic floor, but I mean people can engage their pelvic floor without anything else really coming on, with the exception of maybe like some TA and some like diaphragm movement. But if you just want to know what they're doing and they would consent to having an internal assessment done, then send them over for that, and then we'll say they've got really good awareness, they lift well, or it's like, no, when you're cueing their pelvic floor, they're actually increasing intra-abdominal pressure and like bearing down, right? Because that happens too, where they think they're engaging their pelvic floor and they're basically just like straining, right? So then at least you know when you cue that's what they're doing, right? Because you might not, especially if they're getting lots of like oblique stuff too, you might see that. Yeah. Questions, concerns, debates? Yeah.
Do you think it's worth including some of those in the initial thing that they fill out?
I feel, you know what, it is now. So the health history form has like history of pregnancies and like like gynecological history. It's there. So that's something. I mean, maybe if you saw that in there, for sure, like history of pregnancy, or like reporting incontinence, I would probably dive into that a little bit more in that situation and maybe give them that screening questionnaire, or just talk to them and ask them, has anyone ever talked to you about like just pelvic floor retraining or like anything like that? But I don't think that it needs to like, it wouldn't be like, let's replace the CSFS and put a pelvic health screening. I wouldn't say that's necessary. But I think in the same way that you would ask about like, okay, like do you experience, knee pain when you run? Like to me, like that's kind of like my next question. What about your leaking, right? As opposed to just like changes in bowel and bladder function, which is way too open-ended. People probably half your clients don't even know what that question means. They're like, no, it's been the same.
Especially if they've leaked for like,
it
10
hasn't
years,
changed.
they're like, no,
Yeah,
it's fine.
same.
So one question I always have, and I actually we had this discussion briefly about 2 weeks ago. Whenever and it's on your list there, it's like when we do have clients who are pregnant, and they're, a lot of times in our population, are coming up and they're telling us, hey, I know I've had this problem with my back in the past.
Mm-hmm.
I've had this problem with my pelvis in the past. I'm pregnant or I'm trying to get pregnant, and my question is always like, okay, so when's that ultimate kind of like time you guys need to start seeing them or assessing with them or working with the team?
Yeah, like ideally they would get at least like if they can get their baseline measured before they get pregnant, that's like, then we're like, that's in an ideal world. You just figure out baseline pelvic floor assessment. Baseline pelvic floor assessment and linea alba, like diastasis tension, and get their baseline. Aside from that, they should be screened like early second trimester, usually around 12 weeks,
so,
13 weeks.
12 weeks or so.
And then even then, it's like you can continue treating them and just like, like it might be like Katja Rai saying like their pelvic floor strength is like grade 4 out of 5. They've got great awareness. They can coordinate well with breathing, so you can incorporate like that cueing, and that they're doing that well. And then if they're not having any issues, like no leaking, no pressure, no heaviness, no pain, then like
okay. I think that's a good answer, because I always struggle with letting them, like wanting to let them know in enough time to go see somebody.
Yeah.
Whether it's you or,
Yeah.
or Katja in this case, but like, or like, because I always feel like at some point, especially when they're pregnant. I'm like, I'm not the right person they should be seeing. Not to mean that
Yeah.
we still would work like in a tandem. with
No,
that.
and that's just it. Like, it's not like you have to, send all your pregnant clients away, but I would encourage them to get that initial assessment and get screened. Pregnancy has a huge impact on that piston, like massive impact, and that is one of the reasons why we see a lot more pelvic floor issues in that population, why we see more of the diastasis, right? Like, your center of gravity is thrown off, your central stability, your strategy for central stability is like you're just grasping at straws at that point to try not to fall over, right? And the strategies that we see, they can have a negative impact on like SI joint issues, pelvic floor issues, back pain, knee pain, whatever, right?
I have another question actually.
Yeah.
Just popped into my head.
If
as
you
we're
guys
talking
have
about this.
clients, we need to go by all means figure out, but yeah, you're like, I have a client.
Look, I also have to go. Okay, I'll ask Karlyn about it later.
Thank you guys.
Thanks, guys.
Appreciate it.